Organic silver salts, a routine treatment. I usually employ 0.5% Proterol. The patient, after urinating, injects this into the urethra at least 3, at most 4 times a day. The intervals are made as even as possible, and no interval of less than 3 hours is permitted. The injection is retained 5 minutes by the watch, unless this excites pain, in which event the duration may be reduced to even 3 minutes, or the strength of the solution diminished. The test of the success of repressive treatment is diminution and disappearance of the patient's subjective symptoms, pain, or discomfort. The patient must be impressed with the fact that the success or failure of the treatment is in his hands and that the sign of danger is pain, the cause of pain, trauma. He must be gentle in injecting, gentle in compressing the meatus, and should not repeat an injection in case a first effort fails. Pain is never the same in any two cases. To say that an injection of Proterol to be efficient should be painless is obviously untrue, but each successive injection should be less painful than its predecessor, and the appearance of any new or increased pain at any time is the one signal that calls for immediate consultation. The patient reports every day or every other day for the first week, and but twice a week thereafter, until in the 4th or 5th week the time for terminal treatment arrives. If all goes well, the discharge disappears in a few days. The first urine becomes almost clear, but never quite sparkling. The second urine remains sparkling. There are no subjective symptoms. In from 5 to 10 days, there is often a sudden change for the worse. The discharge increases, the urine becomes more purulent, there may be some swelling at the meatus and pain on urination and injection. This indicates either that the urethra is irritated by the injections or that the gonorrhea is escaping control. Injections should, therefore, be completely stopped. 24 hours later, the patient reports 1. If the symptoms have diminished and no gonococci are found, no injections are given, and the patient reports daily, each day carrying home 2 slides to be smeared with the morning discharge and examined for gonococci. So long as he continues to improve and gonococci do not appear, no more local treatment is given. If the urine remains sparkling for 4 days, the patient is probably cured. He is dismissed for 3 days and the cure verified in the usual way. Page 192. 2. If the symptoms have diminished, but gonococci reappear, the treatment by injection is resumed. 3. If the symptoms have increased or remained stationary, gonococci will almost invariably be found. The decision whether or not to abandon the repressive treatment now depends upon the patient's condition. He should be treated as though this were his first visit, by injections or by expectant treatment. At the end of the 3rd or 4th week, an anterior injection of zinc acetate may be substituted for one of the silver injections every day or every other day. He shall be carefully instructed not to retain this in the urethra. This brings us to the terminal treatment, page 232. If the case is seen late. If the case is not seen until it is well underway, local treatment will, of course, be begun very gingerly, using 0.25% Proterol for 2 or 3 minutes, only for the first day or two, until the sensitiveness of the urethra abates sufficiently to permit of stronger and longer injections. Or 10% Argyrol may be employed. Treatment of the posterior urethra. The urine passed in 2 glasses is carefully examined at each visit. The first appearance of haziness due to pus in the second urine passed shows involvement of the posterior urethra. It must then be treated in the following manner. If the anterior urethritis is not very well controlled, no treatment of the posterior urethra is required at the first appearance of pus in the second urine. Local treatment of the anterior urethra is continued, and if this promptly brings the anterior inflammation under control, the posterior urethra is attacked, as described below. If the anterior urethritis is not controlled before the posterior urethra begins to show subjective symptoms, frequent and painful urination, The physician must elect one of two courses in accord with his prospect of success. If the anterior urethritis is quite uncontrolled, the repressive treatment should be abandoned. If there is still prospect of controlling it, the posterior urethra should be attacked, as described below. When in doubt, stop all local treatment. If the anterior urethritis is well controlled when pus first shows in the second urine, the posterior urethra should be promptly attacked with instillations once or twice a day of 20% argyrol or 0.5% protergol 1 cc to a dose, or by posterior irrigation, very small catheter or very gentle force, with protergol 1 to 2,000, argyrol 1%, or permanganate 1 to 8,000 once a day. The selection of treatment for the posterior urethra depends upon the experience of the physician and the previous history of the patient. If the posterior urethritis begins to show symptoms in spite of this treatment, the patient may be put to bed, hot sitz bath or rectal douches administered twice a day, and the treatment continued. If the symptoms still progress or if the patient is unable to rest, all local treatment should be discontinued and the case treated as one of acute posterior urethritis. When treatment fails, if pain does not diminish with repeated injections or if posterior urethritis becomes uncontrollable, all local treatment must be stopped. The occurrence of balanitis or lymphangitis does not call for cessation of local treatment, but periurethritis does. Other methods of treatment. To develop a system of repressive treatment for acute urethral gonorrhea takes a year or more of personal experience. During that time, one's practice incessantly varies, and having developed a system, the variation continues. New impressions are received from each case, and scarcely any two cases are treated in the same way. Therefore, the practice of no two men can positively agree. Kreisel says, inject 1/8% solution of protergol and retain it for 1 minute, repeating the treatment every 2 hours during the day and twice during the night. After 3 days, a 1/4% solution should be injected every 3 hours during the day and once during the night. At the end of the first week, the strength may be increased to 1/2% to be injected every 4 hours and retained for 5 minutes, while the night injection may be discontinued. At the beginning of the third week, the same solution may be injected 3 times a day and retained for 5 minutes at a time. At the beginning of the fourth week, when the secretion will be found to contain mostly epithelial cells, no or but a few leukocytes, and no gonococci, an astringent and mild antiseptic may be substituted for the morning and noon injection with protergol, but the latter should still be used before retiring. Finger employs 0.25% protergol solutions, warm, and always precedes injection by a gentle irrigation with water to wash away the urine that remains in the canal. He insists that the injection syringe should contain at least 10 to 12 cc's. He retains the fluid at least 5 minutes and expects it to reach the posterior urethra. He injects 3 or 4 times a day. After 3 or 4 days, he increases the strength of the protergol to 0.5%, then to 2%. Then, in the second week, he begins with Largan, 0.25%, and within 2 weeks increases the strength of this to 1%, meanwhile diminishing the frequency of injection to once a day, substituting Oltzmann's astringent injection, page 214, twice a day.